for those of you who don't know me, I'm one of the staff anesthesiologists over at the VA hospital. I'm going to talk today about the history of anesthetic preconditioning and what its clinical relevance might be today. 20 years ago, 3 research groups at 3 different institutions initially described that volatile anesthetics are capable of protecting the heart against myocardial infarction in a way that was identical to pharmacological preconditioning. One of those research groups was here at the Medical College of Wisconsin. These papers were all published almost simultaneously by these 3 research groups in anesthesiology in 1997. So what are some of the objectives of today's talk? Well, the first objective is that history is interesting. So, and we can learn quite a bit about our specialty by learning about some of the history of the research that led to what we do. I sometimes hear speakers here talk in not necessarily derogatory, but in diminishing ways about older research. Oftentimes you'll hear comments like, well, that's an old study, in a dismissive sort of way. And one of the reasons I wanted to present this subject is that oftentimes older research isn't necessarily bad, A, and B, actually establishes what you do as a consultant today. Some of the reading material that I sent to you guys, I'm sure you all got through my chapter from Miller. You probably, the thing is that I'm waiting for the Nobel Prize Committee to call me, because obviously I've cured insomnia with this chapter. I mean, most people just read a couple paragraphs and then they wake up about 90 minutes later drooling on their book. But a lot of the material in there isn't referenced at all because it's older data, and it basically establishes what we do and what the effects of, for example, in the chapter's case, what anesthetics do to the heart and the cardiovascular system. So old data shouldn't just be dismissed as insignificant. I think it's important that we review a lot of cardiovascular physiology and pharmacology in here, because you guys need to be very fluent in that as consultants in anesthesiology. It's something that I think deserves emphasis. And finally, whether you know this or not, all of you as residents, the department itself has an extraordinarily rich history in cardiovascular research. It's produced 3 winners of the ASA Research Award, and 1 member of the department was actually a member of the National Academy of Medicine. And so the amount of research money that the department's gathered and the findings and the discoveries that they've had are a crucial part of the history of the department that deserve to be discussed. Now, another thing that I gave you in the handout materials that I sent to you guys was an updated ABA content outline. This is something that everybody who's in the board process should be fully aware of, okay? And you guys should all have this thing, and you should look at it on a regular basis, because of the fact that all of the questions from the basic and advanced examinations come from it. Today's talk is going to be focused on things like anesthetic effects on the cardiovascular system and ventricular function, which are both covered in the basic exam, and some topics in ischemic heart disease, coronary physiology, that are covered in the advanced exam. So please pay attention to the content outline when you're studying, and take a look at what I sent to you. I have one disclosure that I can make without my attorneys present, and that is that I was a new assistant professor and a minor contributor in one of the labs that discovered anesthetic preconditioning. So I do have some history and something to disclose. The first thing we have to do is we have to define, well, what is preconditioning? What is this phenomenon? The phenomenon is, awfully sounds really experimental when you first start thinking about it. It involves the idea of application of a brief stimulus, an episode of ischemia, a medication, heat stress, followed by its removal and restoration of control conditions, okay? Followed by a prolonged period of ischemia and then reperfusion. Okay, so that's what preconditioning is, the idea of giving something taking it away, and then having a prolonged period of ischemia. This happens in all mammalian species and in every organ system, and has been shown basically throughout in the last 20-some years to basically be a ubiquitous mechanism by which organs and cells are able to protect themselves against ischemic stimulus. So when we talk about volatile anesthetic preconditioning, what that involves is the idea of giving a volatile anesthetic and then taking it away before an ischemic episode. So it's important to emphasize that continuous administration of a volatile anesthetic is not preconditioning. And that's what we always do. Okay, we turn on the anesthetic and that goes on for the whole case, and then we turn it off. We're not preconditioning when we do that. We're just administering it continuously. Now, as I said, all of this sounds awfully experimental. Okay, and you know, the last thing I want to do is bombard you with a bunch of laboratory data and watch you walk out of here in 20 minutes, you know, completely glossed over and not having any idea what I said. The bottom line is that preconditioning, however, has important potential clinical applications. What are some of those? What do we do when we put a cross clamp on the aorta? Okay, what we do when we do that is we make the heart ischemic. There's no coronary blood flow during that period of time in cardiac surgery, is there? We're going to give a bunch of things to be able to protect the heart during cardiopulmonary bypass. We're going to, after the cross clamp's on, we're going to give cardioplegia in both directions to mechanically arrest it, to electrically arrest it. We're going to decompress the heart to decrease its oxygen demand. We're going to reduce the patient's temperature. We're going to put ice on the heart. We're going to do all of those things to try to mitigate the effects of the ischemia. That's what we're doing. But the bottom line is that the heart's still ischemic, period. Okay? And so the idea of putting on an aortic cross clamp is actually an opportunity for us to precondition the heart. If we were to give things before we put that cross clamp on, and then remove them, and then put the cross clamp on, that's considered preconditioning. Similarly, if you occlude a coronary artery during off-pump coronary surgery, that's another clinical example. Okay, surgeons oftentimes will do that in order to facilitate doing the anastomosis. Theoretically, you can precondition under those circumstances. Similarly, you can do it in the cardiac catheterization laboratory. You're going to blow up a balloon, you're going to put a stent in the patient, you could theoretically blow the balloon up for a briefer period of time, let the heart re-equilibrate, then subsequently put the balloon back up to be able to deploy the stent. And that's a preconditioning thing. So preconditioning actually has important clinical examples. Now, the first time that anybody ever demonstrated that volatile anesthetics might be beneficial from the standpoint of an anti-ischemic effect was in 1976. John Bland and Ed Lowenstein did a really interesting experiment in which they took dogs. This was a very common model back then. And what they did is they did progressive coronary artery occlusions of 3, 6, 9, and 12 minutes, and then reperfused for those periods of time. And they summed up the total amount of ST segment elevation that happened during that period of time. And so they used that as a quantitative index of how much ischemia was happening. Then what they did is they did the same experiment in the presence of 1% halothane. Okay, halothane, obviously we don't use that anymore. The only person who has any halothane anymore is George Hoffman, and it's stored in his locker at Children's Hospital. Okay, so, but in the presence of halothane, which is just yet another volatile anesthetic, it had some particular, properties that were a little bit different than the ones that you're using now, but not a heck of a lot. In the presence of halothane, the amount of ST segment elevation that you saw was dramatically reduced. And then when you took the halothane away, lo and behold, the ST segment elevation changed back to the control levels. So this is the first time anybody's ever shown that volatile anesthetics are capable of producing an anti-ischemic effect. 1976 is also the last year that I didn't have a beard. Okay, so a few years later, Rick Davis does an experiment in which, an even simpler experiment, okay, and under these circumstances, what he did is he just took a dog and he occluded a coronary artery to cause an infarction, okay? He had one group where he did that, and he had another group in which he gave halothane for 12 hours after he did that occlusion. And in the presence of halothane, what happened is that this had a direct protective effect by reducing the size of the myocardial infarction. Okay, so that's what it did. It reduced myocardial infarct size. This is the first time this has been demonstrated. A few years after this, David Waltier, hey, I feel like I'm on Barney.
Thank you for waiting. Please hold the line. We'll be right back with you.
We'll be right back. Thank you for that musical interlude. Oh, that's so good. Fantastic. I want to be on a kid's show. All right, so, yeah, I think it's funny. I mentioned Dave Waltier's name, and then all of a sudden the music comes on. So, Waltier, Mahmoud Al-Watiki, who was a cardiology fellow at the time, Bill Schmaling, and John Campine published these results in 1988, in which they showed that halothane and isoflurane, in this case halothane, enhanced the functional recovery of stunned myocardium. Wow, what does that all mean? What's stunned myocardium, Kat?
It's a period of contractile dysfunction after, or prolonged contractile dysfunction after a period of ischemia that is enough to cause necrosis.
That's right. That's exactly right. Everybody hear that? It's a period of contractile dysfunction that occurs as a result of a brief period of ischemia that isn't enough to cause myocardial infarction. Okay, so it's basically on the continuum of ischemia, but it isn't enough to cause myocardial infarction. And so what these guys showed, it's kind of interesting, under control conditions you only see about a 50% recovery in what's called segment shortening, which is like regional wall motion, okay? Segment shortening, but if you give an anesthetic, you get this dramatic increase in recovery. And so as a result of that, what these data showed for the first time was that myocardial stunning can be reversed by volatile anesthetics. Myocardial stunning happens all the time. We see it all the time in the heart room. What happens when you come off a bypass after you've done a cabbage with Dr. Almasi for 3 hours? Okay, well the heart's a little bit ischemic during that period of time, despite all of his efforts to try to protect the heart. Heart comes off, it's kind of sluggish, it doesn't want to contract very well. Pagel says start some milrinone and some norepinephrine in order to be able to get the heart moving a little bit. And stunned myocardium is typically responsive to inotropic drugs. And as a result of that, that's what you see. And so stunned myocardium happens all the time. So we've got 3 things here basically. We've got ST segment changes, we've got infarct size, we've got myocardial stunning, and volatile anesthetics do all of those things. Okay, they all do that. Well, why is that? Okay, that immediately becomes the question. So how is this happening? Okay, what do the volatile anesthetics do to hemodynamics? Ken, what do volatile anesthetics do to hemodynamics?
So volatile anesthetics will decrease systemic vascular resistance.
So they decrease afterload. What else do they do? Anybody?
Myocardial depressants.
They're myocardial depressants. Okay. What else? Anything? They have any effect on heart rate?
At higher concentration.
Sometimes they'll reduce heart rate depending on the experimental preparation. But they're negative, they're inhaled negative inotropes that are vasodilators, right? What does that do to myocardial oxygen demand? It reduces myocardial oxygen demand, right? Okay, so are the hemodynamic effects of halothane solely responsible for what we're seeing in terms of the anti-ischemic effects? Okay, that's the question. Well, you know, in the presence of you know, in these dog experiments, which were animals that were anesthetized with pentobarbital, heart rate actually decreases when you give halothane. So there's another reason for myocardial oxygen demand to go down. Is it solely responsible? Heart rate, myocardial contractility, afterload all fall. Myocardial oxygen demand is reduced. Ischemic burden is reduced as a result of that. So therefore, there should be less ischemic injury as a result of that, if that were the case. Okay, well, if that was the case, then if I did another experiment in which, for example, I measured infarct size and I just controlled the hemodynamics, they should be the same. If I control the hemodynamics with medications like, say, propranolol and nitroprusside, I can get the same hemodynamics with those drugs, and the amount of ST segment changes that we see during that period of time should be identical to halothane. And lo and behold, Ed Lowenstein does this experiment in 1982, and he shows that, hey, guess what? Halothane, what did I just do? Oh my God. Right, oh, here we go. Okay, so halothane actually causes a greater decrease in ST segment changes than if you were just using drugs to control hemodynamics, okay? These are important data from the perspective that they indicate that the volatile anesthetic has an effect above and beyond what its changes in myocardial oxygen consumption might be. And so, and this is crucial data. Hey, just to, as an aside, can somebody tell me who invented continuous ST segment trending in the operating room? Does anybody know who that is? Yeah, you do. Okay, but I'm just saying over here. Anybody? Exactly. John Campine invented that. In the late 1970s, okay, he was a cardiac anesthesiologist at the Milwaukee County Hospital, and he had a friend of his named Mike Cudahy, who had a new company called Marquette Electronics. And he calls up Mike and he says, Mike, I got this cool thing you might want to put in your monitors. Okay, there wasn't much of a patent office at the Medical College of Wisconsin at that time. Cudahy said, wow, this is really cool. This is a neat thing, I'll put it in there. 20 years later, Cudahy sells his company for $850 million, okay? $2 million of that comes back to the Medical College of Wisconsin to endow the John P. Campine Chair of Anesthesia that Dr. Lean currently holds. A little piece of history. Campine was a remarkable guy, incredible scientist. So, what other reasons are there, for example, why volatile anesthetics might have anti-ischemic effects? Well, hey, lo and behold, some other papers come out from the early 1980s. In this case, John Campine was involved with this, along with Gene Seagard and Tom Ebert and various other people from the VA, who demonstrated that Campine was very interested in autonomic nervous system regulation of the circulation. And what they found was that as arterial pressure decreased, the anesthetics themselves actually reduced the sympathetic nervous system response to hypotension, okay? And that's what these data show. These are just this is actually, nerve activity when you're looking at this. And you would think, well, geez, if it's decreasing sympathetic nervous system activity, that's also going to be beneficial in terms of ischemia. So those are a couple of mechanisms right off the bat. What else was going on in the 1980s? There was all sorts of fascinating stuff, because you got to remember, back in the 1980s, this is the infancy of molecular biology. All of the stuff that you guys learned when you were undergraduates, none of that stuff had been discovered at that point. I mean, DNA had first been sequenced in 1975. And the initial Western blot technique was first reported then. Polymerase chain reactions were reported for the first time in 1985. So people didn't have molecular tools to be able to study what was going on inside the cell the way they do now. But they did have a few tools, and one of the things they showed was that during ischemia, there was a dramatic increase in intracellular calcium concentration that happened. And this makes sense, in retrospect, knowing what we know now, because obviously myocardium is an extraordinarily it sucks up a lot of energy. It requires an extraordinary amount of ATP. If you don't have ATP, you can't keep track of the amount of calcium inside your cell. You can't pump it out. You can't resequester it in the sarcoplasmic reticulum, and there's intracellular calcium overload. And this process was also found to be worsened by the fact that neutrophils come into the myocardium during reperfusion, and this just exacerbates this intracellular calcium overload process. In the 1980s, a major thrust of research was, why do volatile anesthetics cause myocardial depression? Why does that happen? Well, it turns out that volatile anesthetics are essentially inhaled calcium channel blockers, okay? And that's one of the reasons that they cause myocardial depression, and that was actually discovered by Carl Lynch and Jelko Bozniak here at MCW, along with Campine, and that was one of the reasons that they caused these things. So if you think, oh, okay, intracellular calcium overload, right? Calcium channel blocker, right? Those things might be good. And lo and behold, Campine and Bozniak, along with one of Bozniak's postdocs, published a study in 1987 in which they showed that they're measuring intracellular calcium content in the presence, under normal conditions here, and during ischemia. And so there's this dramatic increase in the amount of intracellular calcium that happens. And then when you repeat the experiment in the presence of 1% halothane, that intracellular calcium overload is completely abolished. Okay, so as a result of that, the abolition of intracellular calcium overload is yet another mechanism by which anesthetics are potentially anti-ischemic. Let me see here, next one, okay. So at this point, we've basically discovered at least 3 different mechanisms, and there are actually at least 5 that I could think of when I was making this slide. So there's reduction in myocardial oxygen demand, that's one reason. Okay, another reason, a decrease in sympathetic nervous system activity. A third reason, blockade of intracellular calcium overload on the basis of the fact that anesthetics are essentially calcium channel blockers. An attenuation of the effects of reactive oxygen species. There's also an inhibition of neutrophil endothelial cell interaction that actually facilitates that reactive oxygen species release. So there's a bunch of mechanisms by which anesthetics might be anti-ischemic, independent of any preconditioning phenomenon. There's some other laboratories that should be mentioned, and there's one guy's name in particular that you might recognize. Okay, he's still active. Dr. Stowe's got a very active lab over at the medical school, well funded. He's not doing this kind of work anymore, but he's a good investigator. I gotta throw that up to him. So there were some other interesting discoveries that happened during the 1980s that are worth mentioning in this discussion. The first discovery was made by a Japanese electrophysiologist named Noma in 1983 and reported in Nature in a simple letter. Not all major discoveries have to be published in papers that are 15 pages long. And what he discovered was he was the first person to discover an ion channel that was regulated by intracellular metabolism. And the KATP channel essentially was discovered in ventricular myocytes. It's also present in vascular smooth muscle. And what it does is it links cellular metabolism to electrophysiology. So you can think, wow, okay, if cellular metabolism and electrophysiology are linked in ischemic tissue, this thing might be really important. And lo and behold, that's true. The KATP channel stays closed when there's plenty of energy present. When there isn't enough energy present and there's a bunch of metabolites of that energy being gone, ADP, AMP, adenosine, things like that, now we don't have any ATP molecules flying around anymore, hey, lo and behold, this channel opens. Okay, so the fact of the matter is this thing is like vitally important when you're thinking about studying ischemic processes. Another discovery in 1986 by Murray, Jennings, and Reimer in probably one of the most important cardiovascular physiology papers published in the last 40 years, a paper that's been cited more than 6,000 times to date, described experiments in dogs in which brief ischemic episodes were performed before a prolonged coronary occlusion. This was the first description of ischemic preconditioning. This is a landmark paper that subsequently these data have been shown to be ubiquitous across mammalian species and throughout organs. When this paper was first published in 1986, the scientific community basically fell on its ear. Nobody believed the data. Everybody ran off to their laboratories in order to be able to try to replicate this, and they were all successful in doing so. This is a very important finding. For the first time, this described ischemic preconditioning. So there were some players in the ischemic preconditioning process that ended up also playing a role in the idea of anesthetic preconditioning. One of them was Waltier, obviously, we mentioned that before. But another one was a guy named James Downey, okay? And Downey was at the University of Alabama, Birmingham, and he did some experiments in the early 1990s in which he showed that ischemic preconditioning is mediated by things like adenosine receptors and protein kinase C. But some of his data were interesting from the perspective that the results that he was getting were being influenced by what anesthetic he was using for baseline conditions, okay? And that led him to sort of hypothesize, hey, wait a minute, maybe the anesthetics have something to do with this. Another guy that was involved in this process was a guy named Garrett Gross, who was probably the most famous scientist ever at the Medical College of Wisconsin. Gross, I think may end up being the Medical College of Wisconsin's first Nobel Prize winner because of the work that he did. He first characterized a role for KATP channels and ischemic preconditioning in a paper that he published in Circulation Research in 1992. And then during the next 4-year period of time, he did a series of experiments in which he basically showed that pharmacologic preconditioning as a result of a variety of different substances, adenosine, acetylcholine, bradykinin, opioids, were all caused pharmacological preconditioning that was blocked by KATP channel antagonists. Garrett was also a pretty good golfer. He was a pretty good player. I used to play with him every once in a while. That's when before I became a recovering golfer. Now I don't play anymore. I go to 18-set meetings, one hole at a time. Why is this guy important to anesthetic preconditioning? The reason he's important is because he was Waltier's collaborator. They published like 80 papers together over a span of about 15 years. They used to have labs that were right next to each other, okay? And so Waltier learned a lot from Gross and vice versa. Their relationship was symbiotic, and it stimulated Waltier to start thinking about KATP channels quite a bit. Here he is in his laboratory. That's Garrett, and this is another one of his happy customers right down here, right there. Okay, so now I showed you some data earlier about how Waltier and Campine and Bill Schmeling had demonstrated that volatile anesthetics enhance the functional recovery of stunned myocardium, right? So when Garrett was doing these KATP channel experiments, you know, Waltier thought, I wonder if KATP channels are involved in the process of myocardial stunning. And so what he did is he created myocardial stunning by creating a series of coronary artery occlusions and reperfusions, a bunch of them. You can cause myocardial stunning by doing that. And that's what he did. And under controlled conditions, the myocardium was pretty sluggish here at the end of it. It's, if you look down here toward the bottom, my pointer sucks. If you look at this one here, see, it's, you know, the poor cell, the poor heart is looking pretty miserable. These were done in situ dogs. But if you give isoflurane, whoa, you give isoflurane before all of these occlusions and reperfusions, wow, holy cow. Segment shortening responds completely to that, okay? That process can be blocked by the KATP channel antagonist glyburide. What, you're leaving already? I give one lecture every 10 years, and this is what happens, and you leave? You know, I mean, what's the deal? I don't get no respect. That's a setup, by the way. So the idea basically is that, hey, we just shown that the process of anesthetics enhancing functional recovery of stunned myocardium is actually KATP channel related, okay? And so this was really the first evidence that KATP channels and anesthetics might be linked. Now, anesthetics are also coronary vasodilators, aren't they? Can we dispel a myth in this room to begin with today, Dr. Weiss? Does isoflurane cause coronary steal?
No.
Thank you. Thank you. Thank you very much. It doesn't. Okay? I don't want to hear you guys tell me about coronary steal anymore. Coronary steal is the abnormal redistribution of blood flow away from ischemic myocardium toward normal myocardium. It doesn't happen with isoflurane. Isoflurane is a vasodilator, but it's not like adenosine or sodium nitroprusside. It won't cause coronary steal. Okay, so I don't want to hear any more of this. I hear this at the board all the time too. I have candidates tell me that it causes coronary steal, and I just shake my head and I go, oh, this, okay. And we move on to another topic. It's okay. It's, you know, it's like, okay. So the mechanisms for coronary vasodilation by anesthetics were kind of unclear in the 1990s. Everybody knew that volatile anesthetics block the calcium channels in vascular smooth muscle, and that was one mechanism. But that couldn't explain everything. Nitric oxide wasn't really involved. Dave Lirich and Schuler first proposed that KATP channels might be involved in this process, but it was really an experimental data that Brian Kaysen and Bob Hickey produced from UCSF that actually showed for the first time that KATP channels were a major mediator of coronary vasodilation in vivo. And these data were replicated a few years later by my friend George Crystal from Illinois Masonic, and what he showed was that when this was an unusual preparation actually. What he did is he selectively cannulated the left anterior descending coronary artery see a dramatic increase in coronary flow depending on what anesthetic he was using. But in the presence of glyburide, the histograms in the middle, all of them slanted. Glyburide, a KTP channel blocker, essentially is totally abolished the coronary vasodilation associated with any volatile anesthetic. So the idea is, now we've got all these players involved. Okay, we got Downey, we got Waltier and Gross, we got Kaysen and Hickey, and so these three guys were all interested. Hey, wait a minute, what about preconditioning? What about preconditioning? And so what they did is they all did a series of experiments. The first paper that got published was from Downey's group, and this was in an isolated heart model. What they did is they removed the heart from, in this case with rabbits, and set it up on a Langendorf prep. They showed that ischemic preconditioning, PC here, dramatically decreased infarct size. So did preconditioning with halothane, okay, and that was blocked by inhibitors of protein kinase C, which is called kellerethrine, and a blocker of adenosine receptors, which is the theophylline knockoff. Waltier followed that up shortly thereafterwards, again demonstrating that ischemic preconditioning and isoflurane in these two groups both block infarct size. This is a typical way for this kind of data to get presented. Each one of the dots represents an individual animal. This is how we used to present the data. And in fact, if you used glyburide, you'd attenuate and completely abolish the effects of isoflurane. Isoflurane and ischemic preconditioning also produce a greater effect. Okay, so those things were additive. And Kaysen was the last group, and he basically showed the same thing. The infarct size with preconditioning was actually greater than with isoflurane, but he actually used a lower dose of isoflurane than the other experiments had done, and so his data actually suggested that this phenomenon might be somewhat dose related. Okay, so these are the three guys that initially discovered this phenomenon, and so they deserve some congratulations for discovering this. And then of course the immediate question is, well, okay, does this really work? And that's one of the reasons that I'm here today, is to discuss that. Let's go back here. Okay, does it actually work? Well, if you take human myocardium, take a piece of human myocardium like Julie Freed does it. She gets human myocardium from the operating room, and then she works on she does individual cell preps and cannulates microvessels and does this. You can actually take human myocardium and you can make it hypoxic and then reperfuse it. Okay, and obviously under those circumstances you can impose a preconditioning stimulus under those conditions. And lo and behold, if you do that, you can actually show that you can precondition human myocardium in the laboratory. You can also show that all of the mechanisms that have been shown to be responsible for preconditioning of human myocardium, for preconditioning of myocardium in other animals, also apply in humans. So it seems like it would work. Okay, it would seem reasonable that this would be something that you would be able to actually see. So, at least from a laboratory perspective, it would seem to work like in human myocardium, right? Well, what about clinically? Is this actually functional? So, within 2 years after Kaysen published his initial results, there were two research groups, one from Italy, one from Germany, that actually did there were three studies that these two groups did, proof of concept clinical trials. These were very small studies, 20 patients, 40 patients, two groups. The volatile anesthetics were given in a burst. Essentially what they did is they gave a high concentration of an agent for about 10 minutes, turned it off 5 to 10 minutes before the aortic cross-clamp was put on, and then went ahead and did the rest of the operation with a different anesthetic, usually propofol and a narcotic. So this was a preconditioning kind of paradigm in patients who were having coronary artery surgery. What they would measure is they would measure things like troponin release. They would look at the two groups. They would look at left ventricular function, cardiac output. They looked at outcome variables like, for example, length of stay in the intensive care unit, time for mechanical ventilation, things like this. So here's some of the results. Okay, so this is the results from one of the experiments, and you can see at 6 hours after the operation, there's a difference in troponin level in the isoflurane group versus the control group. Okay, so there's a reduction in the amount of troponin release. It suggests that there's less myocardial injury going on there. So that looks pretty good, right? This pretty much solves it. Okay, anesthetic preconditioning seems to work. We should be doing anesthetic preconditioning, right? Is that what everybody thinks? Well, maybe not. Okay, so there have been a bunch of studies that have been done subsequent to this. Some of these clinical trials were well done, smaller scale clinical trials, and they confirmed the initial results. On the other hand, as is typical in clinical research, there were at least a dozen other studies that were completely negative, that didn't confirm these results. And so all of the studies were small. Very few of the studies were more than 100 patients. The largest study was 400. It was a negative study. Only one study showed that anesthetic preconditioning actually improved long-term outcome, 1-year mortality. And to date, there haven't been any large randomized controlled clinical trials in which this has been studied. And there certainly haven't been any meta-analyses that have looked only solely at anesthetic preconditioning phenomena. So at this point, the data are equivocal in terms of whether this actually works clinically. Why? Why is that the case? This seems so clear-cut in a laboratory. It seems clear-cut when you use isolated myocardium. Why isn't this working clinically? Who's having heart surgery? Okay? Think about the VA. Who's going to have heart surgery? Old patient, diseases. Okay? When you do these experiments in the laboratory, what are you actually doing in the laboratory? Are these animals that you're taking care of? Are they healthy? Yeah. Okay, these are healthy, younger animals typically that are getting these experiments done. So the patient population is oftentimes different than what you're actually studying in a laboratory. So the patient's age is an extremely important factor. The older the patient is, the less preconditioning applies. Coexisting diseases have a major effect. Diabetes mellitus has been shown, this was medical college data that my colleague Dr. Kirsten actually found. Diabetes blocks this process. Okay? So does hypercholesterolemia, so does hyperglycemia, so does obesity. Treatment with other medications that patients may be taking also inhibits preconditioning phenomena. Lots of patients are on hypoglycemic agents, for example. Many patients are also taking beta blockers. Those things have been implicated as potential inhibitors of preconditioning phenomena. The other thing that's important to recognize, and these two things go together, what are you doing when you go to the laboratory? You go in there, and I'm talking about this, I talked about it in the beginning, is what do you do in a laboratory? You take a laboratory, you take this animal, you tie off the coronary artery, and then you reperfuse it. You're causing a myocardial infarction, right? Okay, that's what you're doing. You guys do that in the operating room? Is that what you're doing? Okay. No. As a matter of fact, you're not doing that. You're doing everything conceivably possible, okay, to prevent that from happening. Okay? From the first moment that you see an ST segment change, or you see a regional wall motion abnormality, what are you guys doing? You're screaming and hollering, get Dr. Tawil in this room right now. Okay? That's what you're saying. You're saying, get Dr. Zundel, call him up, we've got a problem, we have to do something. So the idea is that you can't necessarily have a phenomenon that's measured, that's endpoint is being measured with infarct size, applied to a clinical circumstance in which the last thing you want is for somebody to have an ischemic episode, okay? So the magnitude of and the severity of ischemia in the laboratory is clearly different than what you see clinically, okay? And obviously you, as the vigilant anesthesiologist that you are, you're going to do everything that you can conceivably do to prevent this from happening. And so that's the most important factor, probably why APC hasn't been seen clinically, because of course we're intervening. We're in the way. We're getting in the way of observing a clinical phenomenon that we might otherwise see. But that's, in a sense, obviously we're trying to do that because we don't like to be involved in lawsuits. And we care about what our patients are doing. So the idea basically is, yeah, the severity of ischemia is different, okay? The amount of ischemic stimulus that's happening during cardiopulmonary bypass on a patient having heart surgery is certainly different than what happens when you purposely occlude a coronary artery. And you guys are the innervating factor. You're the ones who are most important. And if nothing else, the takeaway message of this talk is that the major factor that determines whether or not myocardial ischemia occurs in the operating room and can be mitigated by anesthetics is not anywhere near as important as the presence of an anesthesiologist to intervene. And that's one of the major reasons that I'm here, is to emphasize that. So what about if you give anesthetics continuously? I said something about this in the beginning. We went through this big list of all the reasons that anesthetics might have anti-ischemic effects. We talked about that at length. Okay, and so that's how we do it all the time. We just, Pagel says turn on the isoflurane because, don't use SIBO because Abbott Labs paid Ebert, but they didn't pay me. Okay, so, we can't use SIBO, so we got to turn ISO on. Pagel says turn that on. Okay, good enough. Well, we leave it on for the whole case. The perfusionist is running it, and we've talked about the idea that maybe this should be beneficial. And unfortunately, that isn't the case either. It's really kind of interesting. Some studies seem to support the idea of improved outcome if you give anesthetics continuously. We're talking about long-term outcome mortality. Okay, that's really what we care about, right? We don't want our patients to be dying off. Unfortunately, a lot of other studies didn't, and in fact, we go back to this isoflurane coronary steal thing back in the late 1980s. There was a lot of controversy about whether isoflurane was actually detrimental to patients with coronary disease because it's a potential steal problem. And as a result of that, Slogoff and Keats and my friend Ken Tooman at Rush did these huge individual clinical trials looking at whether or not isoflurane was safe in patients having coronary artery surgery, and they showed, lo and behold, yeah, it's perfect. It doesn't make any difference. It's the same as all the other anesthetics. You get the same outcomes. Doesn't matter. The key thing involved with the whole process was the anesthesiologist's ability to intervene. These are 30-year-old studies that I'm still talking about and emphasizing to you today. So a lot of studies didn't demonstrate this. There have been some recent meta-analyses that seem to suggest that there's a reduction in mortality if you use a volatile anesthetic in comparison to propofol and a narcotic. But again, a lot of the older studies were excluded from this. And currently, right now, there's a huge multi-center international clinical trial that's going to enroll 10,000 patients total, called the Myriad trial, that's going to try to definitively answer whether using a volatile anesthetic is actually beneficial in your patients at risk for myocardial ischemia. Those results are still pending. So, in summary, the history of anesthetic preconditioning is interesting, but may not necessarily be clinically applicable to what we do. The department played an extremely important role in this process and was centrally important in terms of defining not only the phenomenon but the mechanisms responsible for it. But unfortunately, its legacy is somewhat uncertain at this point. I'd be happy to entertain